Good evening, everyone. Welcome to very important session. It is triads in surgery. This is part one video. Okay, so we are going to see the triads in surgery alphabetically. Today we are going to see A, B, C. So the first one is achalasia cardia. So you know that basic pathogenesis is that there is decreased nitric oxide releasing neurons or there is decreased nitric oxide levels. So normally your lower esophageal sphincter should relax whenever food bolus comes there. But here in achalasia cardia, this lower esophageal sphincter fails to relax. That is why there is obstruction present at the level of lower esophageal sphincter. So whenever this is happening, obviously patient cannot have food bolus going smoothly into the stomach. So the first one will be dysphagia, difficulty in swallowing. Second one, as the patient is having all the food here, it will go in a reverse manner. So there will be regurgitation of food or the liquids. Then obviously patient is having difficulty in swallowing, so the patient stops eating. So there will be decreased intake of food. That is why gradually there will be weight loss. So these are the three classical features seen in achalasia cardia. This is the classical triad we see. So you can remember them with mnemonic draw. D for dysphagia, R for regurgitation, W for weight loss. Okay, right. Moving to the next one, Algrove syndrome. This is also called triple A syndrome. Okay, so what is the other name for Algrove syndrome? It is triple A syndrome. That means there will be three A's here. What are the three A's? So you can remember the first A is related to your lacrimal glands. So there will be decreased tear production. So there will be alacrimia. Then second A is what we have seen just now. That is nothing but your achalasia cardia. Then third A is related to your adrenal insufficiency. There will be adrenal insufficiency. All right. This is regarding Algrove syndrome, which is also called triple A syndrome. Right. Moving to the next one, Anderson triad, which is also called Mackler's triad. Again, this is related to your perforation, especially at the lower end of esophagus. Okay. So whenever you have got perforation in the lower end of esophagus, obviously the contents which are present within the esophagus will be extravasated. So what will be there? There can be even, of course, you have air also, one of them. So you have got something called subcutaneous emphysema, right? Then you have got, see, basically, why is this lower end of esophageal perforation is happening when the patient is trying to vomiting forcefully? So there is an increased pressure within the lower end of esophagus. So there will be usually vomiting initially, which is the predisposing factor, right? Then you have got, because there is extravasation of contents from the esophagus into the mediastinum, there will be pain. So there will be usually chest pain. All right. So this subcutaneous emphysema can be seen as a V sign, or there will be, you can actually look at X-ray to visualize this. So there will be pneumomediastinum will be there. Okay. So you can remember this components of macular triad easily. So M for mouth flow, nothing but you're vomiting. Then A for air in the mediastinum, nothing but your pneumomediastinum. Then C for chest pain, right? So these are the most important three components of your Anderson triad, which is also called Mackler's triad. Okay, right. Moving to the next one, Beck's triad. So Beck's triad is very important one again. Usually you see in case of cardiac tamponade. So what happens in cardiac tamponade? Because there is a rapid accumulation of fluid or the blood within the pericardial cavity, so the heart is not able to pump normally. properly with adequate force of contraction. So what happens? There will be decreased venous drainage into the heart. Okay. So as there is congestion within the veins, you have got distended neck veins. Now, again, because the heart is not able to contract properly, there will be decreased cardiac output, which is causing your hypotension, right? Then, obviously, your lub dub or the other heart sounds are normally maintained by your normal force of contraction. Because the heart is not able to contract properly here, you have got something like a muffled heart sounds. That means they are heard something like very farther away. Like, they are very low amplitude, very less intense heart sounds will be there. It is called muffled heart sounds. Okay. So you can simply remember distended neck veins, muffled heart sounds, and a decreased BP. Okay. Right. This is regarding Beck's triad in cardiac tamponade. Right. Next one. Borchardt triad. Again, this is a very important thing. Usually we see in case of gastric volvulus. Where do you see this? Gastric volvulus. Volvulus is nothing but twisting of an organ around its axis. So in gastric volvulus, what is happening means, see, normally whenever this stomach is folding upon itself, it has got two types again, organoaxial and mesenteric axial. So whenever stomach is having volvulus, what happens? Obviously, the first thing will be having, you are having upper abdominal pain. First feature will be upper abdominal pain. Then, because the stomach is twisting upon itself, whatever the contents that are present proximal to that, they will try to come out, right? And there will be severe retching. There will be severe retching with or without vomiting. Usually there will be vomiting present. Then when you try to insert a Ryle's tube, obviously because you are having an obstruction or the stomach has twisted upon itself, you are not able to pass the Ryle's tube. Okay, so it is nothing but your inability to pass Ryle's tube. Okay, so these are the three important features of Borchardt triad. Okay, this is seen in case of gastric volvulus. Please remember, one is upper abdominal pain because the stomach is twisting upon itself. There will be pain, obviously. Second one is retching, and third one is inability to pass rails tube. Again, you can remember with the mnemonic URI. URI. Okay, right. Next one, Budd-Chiari syndrome. You know that basic pathogenesis in case of Budd-Chiari syndrome is you have got either hepatic vein thrombosis or IVC web formation or the thrombosis. So where is the fault actually? Hepatic veins or IVC. So there is obstruction to the venous drainage of the liver. Whenever you have got this kind of a situation, obviously there will be congestion within the liver. So whenever there is congestion in the liver, there will be hepatomegaly. Usually it will be painful hepatomegaly. That is why you have got usually right upper quadrant or upper abdominal pain will be there. Then, because in the later stages your liver will have dysfunction, obviously there will be ascites which is happening there within the peritoneal cavity. Okay, so these are the three important components of your Budd-Chiari syndrome. This is the classical triad we see here. Okay, one is hepatomegaly because of the congestion of liver. Second one, there will be pain obviously, and the next one is ascites. Okay, right. Then coming to the next one, Carney's triad. Please remember there are three important organs we need to remember. One, lungs, stomach, and adrenal gland or the sympathetic ganglia. So usually in lungs we have got something called pulmonary chondroma, right? Then in stomach you have got GIST, gastrointestinal stromal tumor. Then in the adrenal you can have pheochromocytoma. The same thing if it happens in the extraadrenal sympathetic ganglia, that is called paraganglia. Okay, so these are the three components of your Carney's triad. All right, then coming to the next one, Charcot's triad. You know that Charcot's triad is normally happening in a condition called ascending cholangitis. Itis means obviously inflammation. So what are the basic components of your inflammation? First one will be, that the classical scale or dollar, ruber, tumor. Obviously, here also you are having main your common hepatic duct. Sorry, so you are having mainly problem with the common hepatic duct or even common bile duct. This bile duct or this thing is inflamed. You have got inflammation. So what are all the things present? Obviously, there will be pain. Then because of the inflammation, there will be fever. And because it is happening within the biliary system, there can be jaundice. All right. So PFJ. And you need to remember a specific thing. They will not happen like continuously. They will be happening in an episodic manner. That is why there will be only intermittent pain, intermittent fever, intermittent jaundice. All right. So just remember cholangitis. Itis means inflammation. So what are all the classical features? Pain, fever, jaundice. Okay. Right. So usually in cholangitis, you will be having fever with chills and rigors because of the ascending infection. Okay, right. Then next is your very important one, Curarino triad. Again, this happens in a syndrome. Actually, the syndrome is called Curarino syndrome. It is nothing but a congenital caudal anomaly. As you come towards the tail end, you have a group of things which is combinedly called Curarino triad, which is also called ASP triad. Okay, ASP triad. So A for anorectal malformation. What will be there? Usually there can be stenosis or there can be imperforate anus. Imperforate anus. Okay, this is the picture showing your imperforate anus. This is nothing but your CTPLV, crossed table position, like lateral view X-ray. Okay, then S for sacral malformation. Usually there will be, as you can see here, AP view of your pelvis should show sacrum here, but as you can see, this is empty. So it is nothing but your sacral agenesis. Sacral agenesis. Then and there will be something called presacral mass. What is that presacral mass you have here? It can be either dermoid cyst or teratoma, or it could be anterior meningocele. So these are the three important components of your Curarino triad, which is also called ASP triad. A for anorectal malformation, usually in the form of imperforate anus. S for sacral malformation. P for presacral mass. Right? Next one. Cushing's triad. We know that right from our UG days, we've been by hearting the components of Cushing's triad. You know that there will be raised blood pressure and then bradycardia, and there can be irregular breathing. Today, I'll let you know how to remember Cushing's triad in a conceptual way. See, basically, Cushing's triad is something that we see in raised intracranial pressure. Okay, so wherever you have got raised intracranial pressure, you see something called Cushing's triad. You need to remember one formula, that cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. This is the normal formula. Okay, so it means that only when you have got mean arterial pressure adequately, you have got ICP like maintaining in a normal way, right? Whenever there is ICP is raised, obviously your mean arterial pressure has also, it should be adjusted. Then only your cerebral perfusion pressure will be maintained. Okay. Now let's apply the same thing. What happens in case of a, let's say for example you have got some head injury or even some other conditions where you have got raised intracranial pressure. So what happens now when there is raised intracranial pressure happening? There will be sympathetic stimulation occurs. There will be sympathetic stimulation that will be happening in the body. So whenever there is sympathetic stimulation, obviously BP will be increasing. Okay, but because there is an increased BP, there will be aortic arch. You know that there will be aortic body is there. So as a response to your raised BP, it will take a feedback mechanism. So there will be bradycardia to reduce, in an attempt to reduce that blood pressure, there will be bradycardia usually. But this Cushing's triad or Cushing's reflex is something that will happen in a stage wise manner. So initially there will be raised BP, then to compensate it there will be bradycardia. But once there is decompensated rise in intracranial pressure, see, no matter what happens, At one point of time, it will be uncontrollable. So once the raised intracranial pressure is at a point way too high, then what happens? Your brainstem will try to, it will usually herniate. And you know that your respiratory center is present in brainstem. So whenever this respiratory center is damaged, what will be there? Obviously, there will be agony of the breathing. There will be irregular respiration. And ultimately, there can be respiratory arrest and even cardiac arrest also. Okay. So these are the three important components happening in case of your Cushing's triad, which is also called Cushing's reflex. Okay. So please remember, it's a concept. Whenever you have got rise in intracranial pressure, whenever there is rise in ICP, your mean arterial pressure tries to increase by sympathetic stimulation, which will cause rise in BP. To compensate, to reduce the BP, there will be reflex bradycardia. And in the last stage of raised intracranial pressure, your brainstem will herniate. So that causes respiratory centers damage, which will cause irregular respiration. Thank you.